Thank you for this opportunity. I'm impressed with the numbers. I was a little terrified by the questions that were being asked, although the good sign was that I don't need to probably talk about half of what I was thinking I needed to talk about. So you could show the first slide. And so you have the slides there, and I would rather do this in a little more interactive fashion. I saw one number thrown around that I just wanted to clarify. So what's the difference between type 1 diabetes and type 2 diabetes? Anybody? Right. So type 1 diabetes, insulin-dependent diabetes, what used to be called when I was growing up, juvenile diabetes, largely affects younger people, and it's the one that insulin required, it's insulin requirement, and it affects about 1% of the population. So not the 10 million that was in your notes, but rather closer to 1 million. So in this room, there are probably one or two type 1 diabetics, proportionally, and certainly I'm sure a few of you have family that are type 1 diabetics. So it's a relatively common disease. It is certainly treatable, but it's not curable yet, and that ultimately will become a point of debate. So how is diabetes treated now? What do diabetics do? Somebody at this table here. How is? Insulin. Okay, and how is the insulin delivered? Via a needle or a pump. All right, and pump we're going to talk about, but most people don't use a pump. So it's done by a needle, an injection. Anybody know where? This table? Where is the needle? Is it in the blood? You had it right. You were pointing under the skin. So subcutaneous insulin injection. How many times a day? This table. How many times is insulin injected a day? A lot? Okay, let me go back 10 years, 20 years. It was injected once a day. Typically in the morning, it would take kind of half the day for the insulin to be absorbed, and at the middle of the afternoon, there would be a low blood sugar as a result because the glucose, the insulin had finally gotten absorbed. In the middle of the afternoon, there was hypoglycemia as a result of that low insulin. About 20 years ago, people figured out that that way of injecting insulin once a day resulted in the complications of diabetes. So diabetes is the leading cause of blindness. There's a large vascular component to that disease. And so there is an issue associated with diabetes treatment. And so we move now to multiple insulin injections a day, 2 or 3 times a day. And also 20 years ago, people developed these various glucose monitors. You would stick yourself, get a sample of blood, measure the glucose, and you would see in the morning you were at 10 instead of 5 or 15 instead of 5, and then you would adjust your insulin accordingly and report largely to the doctor every few months how you were doing. And so with multiple insulin injections a day, one got better control of the glucose. The challenge with one injection a day or even multiple injections a day was that there is a big risk of going hypoglycemic. If one has too much insulin, that's a big problem. You go into a diabetic coma. If you had too little insulin, so your blood sugar would be a little high. So the set point of your body would be a little bit under the amount of insulin you would need, so that you would always be oscillating at around 10 or 15 instead of the 5. Multiple insulin injections got you closer to the 5 than the single injection a day, but still was imperfect. So as a result of that, there were 2 approaches that have evolved. One which is used now is the pump. You can see it on the upper right-hand corner, a wearable pump that would deliver insulin over the course of the day, a little bit at a basal rate, a slow amount sort of overnight and between meals. But when you had a meal, when you knew you needed more insulin, you would push a button on the pump and you would get a correspondingly greater amount of insulin. Also tied to that was a glucose monitor that worked sort of well now, and that's shown on the left-hand image of that upper right image, where you would measure the glucose continuously and you record it and use that to inform the user, the diabetic, about how much insulin to deliver, and that would be sort of an open loop control mode that we will be talking about more in the next few minutes. The alternative to that is the cell delivery, whether it's islets or pancreatic precursors or embryonic stem cell derived, that sort of was added to a tea bag. I like that terminology. A microcapsule in my part of the world that would protect those cells from rejection, keep the cells confined, and have other functions that we will end up talking about over the next few minutes. The upper left corner is a new kind of sensor that you probably have seen, created by Google X, that would actually, rather than measuring the glucose concentrations in the tissue under the skin, would measure the glucose concentrations in tear fluid and would be part of a contact lens that is being developed by Google or Google X. And so with that, I think you have enough introduction to the story and the two sides of the technology part of this question, pumps versus tea bags.